Good evening. So, welcome to this fresh session of a knee joint, the nice knee joint, because actually the knee joint is really nice. So many things we will learn in this case. That is the conceptually and obviously from the anatomical aspect, right? So, without further delay, let's start. Okay, so that's like femur, right? And we have talked about the upper part of the femur. So over here our focus would be only on the lower part. That is where the knee joint will be coming into picture. So here is the lower part. Now in this lower part there are specific things which are of very much importance, because we'll be focusing these terminology when we'll be describing that where exactly the anterior cruciate would be attached, where will be the posterior cruciate. Yes, that's good. That's good. All right. Okay. So what I was talking about, that this is the lower end of the femur, and this is our medial condyle, and similarly on the opposite side, that's the lateral condyle. Some terminology will help us in properly identifying the attachments, right? And in between these two condyles, we'll call it intercondylar notch, right? Because it's like a notch, and that's why intercondylar notch, right? Whenever we use the word inter, that is inter-school competition, inter-college, international, that is between school, college, national, nations, respectively. Okay, this one, this portion, right? That is what is called as the epicondyle. So this would be the medial epicondyle, and similarly over here that would be the lateral epicondyle. Now see, the lower end of femur, right, that has got some very special areas which are to be seen. One which was very important, especially if you remember when we were dealing with adductor magnus, right? Now, how adductor magnus was, it was like the whole muscle was attached on that linea aspera, and then there was a gap, and then there was a second head which was attached on a only small area. This was leading to formation of what's called as the adductor hiatus, right? Through which the vessels, they were passing from one area to another area, anterior to posterior. So this portion, that is what is called as the adductor tubercle, right? That is what is called as the adductor tubercle, and it is the adductor tubercle where this second head of adductor magnus would be attached. So friends, here is the adductor tubercle. That's the point, right, where the adductor tubercle is located, right? The prominence. Yes, one more thing. Say this sharp line, right? That would be the, now see, we have rotated it, right? We have rotated it. So these are all what is called as the supracondylar lines, right? Supracondylar lines. And we'll see that this one, because now we are looking from the posterior aspect, so it would be medial supracondylar line, right? And similarly, this one would be the lateral one, right? Lateral supracondylar line, right? I'm going through these areas quickly so that we can focus on the main stuff bit properly. All right, so here is the first vision of our right knee joint, right? We'll be dealing with the right knee joint through and through. So that's the tibia, and this one is fibula, right? Tibia is medial, so this is the medial side, and that one is the lateral side. All right. The full view, right? The full view. Over here, we are just interested in one thing, and that is tibiofibular joint, the joint between tibia and the fibula. So this is the tibiofibular joint. Now, actually speaking, there is very less movement in either of these joint, right? So very less movement. And because there are two, so we'll call this one as proximal tibiofibular joint, and we'll call this thing as the distal tibiofibular joint, right? All right. So we talked about femur, lower end. Now this is the upper end of tibia, right? If you really see in more detail, right, this whole thing, right, this part, that's the area which is of utmost importance, because that would be the articular area. So we'll see it separately. Just looking at this, right, over here, this one is lateral condyle, because over here this is a medial aspect, so this would be the medial condyle, right, the prominence. And that's the proximal tibia, right? I think that proximal tibia. Watching further, yeah, here it is. Now comes the interesting part. This is articular surface, right? That is the articular surface. Now, in case of hip joint, if you remember, we talked it like that was acetabular labrum, which was like a C-shaped. So this is the area which was like articular one. In between over here, there was that ligament which was connected. Now over here, it is divided into two parts, right? So over here, this is the lateral part, and this one is the medial part, right? These are the articular surfaces, And in between these articular surfaces, no big rocket science, right? It is called as the interarticular area. Now it is this interarticular area where we'll see some of the important structures, right? One of them would be the like those cruciate ligaments, anterior and posterior. Okay, let's rotate this bone, right? Because we want some important landmarks to be seen. Now, when we see this is anterior portion, right? That one is posterior, right? Adductor tubercle. You tell me, where should it be? See, adductor tubercle is as such, it is, say you can, it is on the side, right? Say over here, if you look at this bone, this is anterior, this is posterior, right? So it is on the side. That's where the adductor tubercle is, right? Test. Right now, I'll let you know about the test. Okay. All right. Coming back to this. Say, again, we are watching it from the side. So on the anterior part, this portion, right? That one which is pretty rough, but it's a big area. This is what is called as the tibial tubercle. Now this tibial tubercle, that is a place where the quadriceps tendon is going to land, right? The quadriceps tendon, it will come all the way and then it will land over here. Now you know that quadriceps, right? It is someone which is comprising of 4 heads. So all of them, right, they will combine and they will land it at this point, that is tibial tubercle. Right. This one, right? That is what is called as the facet for fibula, right? That is facet for fibula. So same thing, just watch it over here and it gives much better clarity. And that's where we say that this one would be the head and that one would be the neck of fibula, right? Okay. Now, why this is shown over here? Because the gap which you watch, right? The gap, the classical gap, the wedge-shaped gap, this gap would be filled by what's called as the meniscus, right? It is the meniscus. These meniscus, they are like shock absorbers. They are like shock absorbers. So you will see the meniscus over here and over here, right? And meniscus is singular, and when there are more than one, we will call it menisci, right? Menisci. Okay. In this, when we learn about the knee joint, there is one clear concept, and that is that knee joint is divided into two separate halves, right? So it is divided into two separate halves. And in between, it is this area. There would be cruciate ligaments. Right? There would be cruciate ligaments. Ligaments because one would be anterior and second would be the posterior. Anterior and posterior. Now this anterior and posterior, these names, right? These names, they are given with respect to that where exactly are they attached on the tibia, right? So we'll write it over here with tibial reference, right? Tibial attachment or tibial reference. That is, we'll see it in more detail. But just to give the idea that when we say anterior cruciate ligament, that means it is attached on the tibia. On femur, where, right, it would be different. But at least on the tibia, it is attached anteriorly. Let's see it in more detail. Okay, before that, we just see this important bone, right? Remember, we are just for the orientation, we are watching a right knee joint, right? So this is what is called as the patella. We also call is the kneecap, right? But there are few important points, important keywords which are associated with it. This is the largest sesamoid bone, right? This is the largest sesamoid bone. Question: what exactly is sesamoid bone? Well, sesamoid word, it came from seed like, right? It is like a seed. And this is a bone which is in tendon. So over here we have quadriceps, right? We have got the quadriceps tendon. And what's the function of such bones? Such bones, they give mechanical advantage, right? They sometimes they change the direction of the tendon so that that pull, that action, right? That would be in a different plane, and at the same time they'll be acting like a cushion effect, right? So when we see it from side, How are we seeing it as anterior or posterior? Means what anterior posterior? Because see, anterior or posterior, it is for any of the bone, right? It is so prominent because all these condyles, right? They can be seen extremely, say, effectively from the posterior aspect. Okay, coming back to this, say this would be the direction of quadriceps. That's the thing, right? This is the quadriceps tendon, right? And it will land on, we have already seen this, right? This one, and that is tibial tubercle. Okay, about the, if you're asking about cruciate ligaments, just wait, right? We'll just see that. Okay. Now, one very interesting thing about the patella. This particular bone, if you watch, this is the posterior surface, right? We are watching it from the posterior side. It is quite smooth. So that's where we're creating this articulation. In that, say if I draw it something like this, if I draw it like this, so with the extended and the flexed knee, the position of patella would differ, right? That would be different. This above one, right? What we saw there. This is when the knee is flexed. When the knee is flexed. When the knee is extended, this patella will come slightly down, right? And will lock the knee. That's the location. When the knee is extended. So just do remember that when the knee is extended, this patella will be moving slightly down, right? It means it will be with condyles. So over here, this patella will be with condyles, right? And when the knee is flexed, so this area, this above area, right, which I'm marking like this, that is also called as the central articular area. So we can write it like central articular area, right? The next is, now we have a complete look. Say this space will be covering this space, right? That is where we'll be putting those joint cartilage. True? So over here, they will be like joint cartilage. And it is this central portion, right? This. That would be the area for like cruciate ligaments. Cruciate ligaments. Then to support this entire joint, right, we'll be having something like this. We'll be having something like this. And they will be called as collateral ligament. Right? We'll watch all of them. Collateral ligament. So which is on tibial side, so we'll call it a tibial collateral ligament, which is on the fibular side, we'll call it the fibular collateral ligament, right? So over here, and this one would be like fibular collateral ligament, right? I'm just writing in short because in any case, we'll be watching it in more detail. Okay, here it is, the next one. Now comes the real stuff, right? This is interesting. These are now real tissues. Watch for this. The menisci, which are over articular surface. So see how glistening, shining, right? These are, right? And over here, watch for this, right? So they are menisci or the meniscus medial and lateral. So they are menisci, which are over articular surface, right? over articular surface. So here it is the medial portion and medial part, and that's the lateral part. Now it is worth watching them in slightly more detail. The entire purpose of lower limb or the knee joint is the stability, right? It's the stability. So if you compare, right, in case of shoulder, what was happening, where the mobility was more important. So that's why the surface, right, it was like that scapula was pretty flat, and then the head was moving over it, right? The head was moving over it. Now over here, it is necessary to give the stability. So that's why we are trying to create more depth, right? So that's what the entire purpose. Now these are all flexible, right? They are all flexible fibrocartilage, right? Fibrocartilage. Now if you look at this lateral one, lateral, right? This is the lateral one. This lateral one is almost full, right? Almost like a full circle, full circle. See, it is almost attached, right? But what I'm interested in, that if we take a section of this, if we take a small piece of this, and when we watch it from the side, it would look like this smoothly. It will look like this, right? So this means that there is thick, okay, thick outer edge, right? And this one is thin inner edge. So thick outer edge and thin inner edge, right? And one another interesting thing is that when you really compare these menisci from both the sides, right? One is, okay, this is lateral and it is like a, I would say, full circle, right? It is like a full circle, right? This one, that is medial meniscus, right? So this is the medial one, and this medial one is almost a C-shaped. It is a C-shaped, right? So this is C-shaped. If you consider that how much they move, right, you'll find that it is the lateral one which is more mobile as compared to the opposite. So this is less mobile, right? These lateral and medial menisci, they are attached to the joint capsule, so thus they give strength, right? So over here, and we'll also see it in another, say, image, another angle, from the another angle. This is attached to joint capsule, and you'll appreciate this much better, I think, in the next image. Yeah, here it is. See how snugly, how effectively they are connected with the, they are merged with the joint capsule, right? See over here, right? They are so nicely merged, right? As if it is all a single package. So here, that's what we see, that these menisci, they are merging with joint capsule. Fine. Okay. Now comes for whom we were waiting since long, right? This one, I'm zooming it first. I'm talking about the structure which is like this and this. This structure is what we are talking about. Unzooming, right? Removing. So that's nothing but anterior cruciate ligament. Now, normally when we say cruciate ligament, we feel that they are like this. No, no way. No way, they are not like that. So I'm removing it. Orientation, we are dealing with the right side, right? This is the right side. So that's why this one would be the medial part, this one would be the lateral part. Now in anterior cruciate ligament, right, as we said that it is the tibia which is more important, right? As you are asking. And yeah, this is anterior view, right? Remember, this is anterior view. And in this anterior view, we have like, say, removed the patella, right? This anterior cruciate ligament on tibia, right? You will be requiring bit of visualization. I'll slow down over here. On tibia, it is connected on the anterior aspect, right? So yes, this is anterior aspect, right? Because this is anterior view. So on tibia, it is connected anteriorly, all right? Where exactly? Into the intercondylar area, right? So it is intercondylar area. So because it is anteriorly connected, so we'll call it anterior cruciate ligament, right? Where exactly in case of femur, where is the second end? Now that second end, to see that second end, we have to go back. We have to watch from the posterior aspect, right? But before we go and we see the posterior aspect, because the moment you will see, you'll be able to say it very clearly, okay, yes, done. This is easy. I really want you to visualize. There were lateral condyles, right? There were two condyles, lateral and medial. We want to deal with lateral condyle, right? So lateral condyle. Now in that lateral condyle, that full lateral condyle, so there would be a medial aspect and there would be the lateral aspect. So I'm interested into the medial aspect. So it is the medial aspect of lateral condyle. Now this lateral condyle is a big one, है ना? This is also a lateral condyle, right? Because it is that entire lower portion is the lateral condyle. So we would say it is going posteriorly. So to be scientifically correct, we'll say posteromedial. When we say posteromedial, it makes sense. It makes sense, right? So that means we are dealing with, if this is the whole condyle, this is anterior and this one is posterior. So we are dealing with the posteromedial aspect of lateral condyle. Now, even that, when you say posteromedial, so it is a big area, right? Whether superior or inferior, so we would say superior. So now it makes a full sense that we are dealing with superior and posteromedial aspect of lateral condyle, right? Still, if there is some confusion, will be completely removed as we see this done. Now this makes a simple clarification. So easy, right? This is, don't see, this is not the structure we are talking about, right? No, we are talking about, right? Just forget about this other structure. We are talking about someone. See, can you look at this? A very shy attachment, right? That this one we are talking about, right? See, because this smart posterior cruciate, this is posterior cruciate, right? Posterior cruciate ligament, right? Because over here posterior cruciate ligament is like, there is so much of dadagiri of this posterior cruciate ligament. So this bichara anterior cruciate, right, he is very shyly attached to this portion, right? But which portion is that? This one is lateral condyle, right? And then we said the posterior part. So this is already a posterior part, right? We are just looking from the posterior. So posterior view, I would write, right? That would make things easy. And to that lateral condyle, we said the medial aspect. Yes. So this portion is the medial one. So now we are clear, but this entire thing would be the medial one. This entire thing would be medial one. No. We say that it is only the superior and the posteromedial. Clear? Right? See, I remove this so that we watch this. See, I'll zoom it also. This one, this one, right? This shy structure, that is anterior cruciate. Still we have got lots of other views, right? We'll see that this anterior cruciate, the way it looks very shy, right? No, it is very smart, right? And we'll see that. But at least at this point of time, this much is clean, right? So it is not the inferior portion, right? We are dealing with the superior one, right? So this is superior, posterior, and medial aspect of lateral condyle. All right, but let's make our funda. And right now, don't worry about the posterior cruciate, right? I just told you, we are not yet even seeing its attachments. Here it is. Here it is. See. It is the lateral condyle, right? The lateral condyle is so big, right? That entire bulge, that is the lateral condyle. So we spliced, right? We just cut down, right? Mercilessly, we just cut down this lateral condyle, right? Cut down, right? Without any heart, right? We just cut down. As it is sliced, now this chupa hua anterior cruciate ligament is seen very handsomely. See, so good. Over here, I'll first just highlight it, right? Over, oh, sorry. Here, this one, so that you know that what you are dealing with, right? This one. That's the anterior cruciate ligament, right? Where it's starting from here, right? That is, so this one would be the anterior aspect, no confusion. This one is the posterior aspect, very clear, right? See the prominence, right? So this one is anterior, this one is posterior, and on tibia, right, it is connected anteriorly, so it is anterior cruciate ligament. Bus, done. And then all the way it is going back and it is connecting to posteromedial aspect, and in that case, to be very specific, superior and posteromedial aspect of the lateral condyle, right? To see this thing, I just remove this, and now you can have a look. This one is our anterior cruciate ligament, right? Now clear? Which one? Which one? That posterior view? This one? This is in fact the angular view. This is in fact the angular view. And this one is posterior, that I have already written. Okay. Now we are watching the precise location, that where exactly it is. This one is anterior view, right? I'll keep on writing. This is the anterior view. So this one is tibia, and on tibia, it is this intercondylar, right? Intercondylar area, and that's where this is the on tibia, where anterior. Now for the cruciate, we just write this anterior cruciate ligament, right? It becomes much easier. Now, what are you asking? In previous picture, we saw cruciate emerging from anterior part of femur. Which one? Anterior cruciate ligament from anterior part of femur? No way. No way. Not possible. Where is it? Gaurav, take care. We are just dealing with anterior cruciate ligament. If this is the anterior cruciate ligament, where is it? It is connecting to anterior part of femur. Anterior part of femur to is here, right? Cruciate ligament will never come over there, right? Got it? Remember, it is the tibia. Sorry. It is the tibia which is important, right? Do remember that it is the tibial attachment, right? That's the star, tibial attachment. Okay. So, so this is the anterior attachment, of anterior cruciate ligament, and it is on tibia, right? And here it is. This one is the posterior view, right? Posterior view, right? This entire posterior view, and if this is one, this is the lateral condyle, correct? Lateral condyle. And in that lateral condyle, if we just see, we say this is inferior part, this one is superior, done, and this one is condyle. So this area, this blue area which has been marked, so that one would be the medial aspect, right? It's because this is lateral, this is medial, so this one is medial, and obviously this entire unit is now posterior. So crystal clear, that is for the femur, it is superior and posteromedial part of lateral condyle. Now normally when this entire sentence is written, it looks like that how tricky it is, but now it becomes easier. So that's why I always insist that when you revise, you do speak that it is the superior and the posteromedial aspect of lateral condyle where the anterior cruciate ligament is connected on the femur, right? When you really speak that thing and you visualize, right, your entire memory process will be much enhanced. At the same time, you are scientifically so correct that when you write it or when you speak, simply because usually people would miss the superior or the medial, or it would be said just the lateral condyle. But now when you know that it is this location where it is precisely attached, the person who is asking a question, right, he'll know that your concepts are crystal clean. So in order to make this thing in the form of a habit, when you revise, you do speak certain keywords which I am trying to write down, right? So always speak those words. You speak, you read, so then it will become part and parcel of your brain, right? So reflexly you will speak it like that. Okay, and just to avoid any confusion, we are dealing with anterior cruciate ligament, correct? Okay, moving further. Yes, see this, right? This is an excellent view. Means there cannot be any doubt about it. Say this is femur, right, where it has been cut, that condyle has been cut, right? And this is the tibia, and without my any explanation, you should be able to see that yes, this one is anterior cruciate ligament. Now we said so much about anterior cruciate ligament, but what's the purpose? What's the purpose of these cruciate ligaments? There is an awesome purpose. And the purpose is, say there is tibia, there is femur, right? And they both are gliding. But as such, if you see that muscles are attached on the posterior aspect, anterior aspect, right? So muscles, we can't say that only the anterior muscles are powerful. Even posterior muscles, they are equally powerful. So there are chances of the backward slip of the femur. Femur might slip off if there is no one to just hold it, right? So that is where the anterior cruciate ligament will be acting like a big strong rope, right? What it will do is it will prevent the femur from backward movement, right? So we'll say in big that it prevents backward movement of femur, because over here it is strongly that base, this is acting as a base, right? And from there a tight sling has been attached so that it will keep on pulling the femur, that no, don't go back, right? It will hold it. So that's the purpose. This is the purpose of this anterior cruciate ligament. Now this is much easier, much easier, posterior cruciate, because it is in just one plane, right? So this is posterior cruciate ligament. For proper orientation, let's first get properly oriented, that where exactly we are watching. This is a posterior view. Okay, this is a posterior view. And when this is a posterior view, so this one would be the medial and this one would be the lateral. No doubt about it, because here is fibula, right? So fibula is lateral. So that is medial and lateral. That portion is settled. See this? This is where the medial meniscus would go, correct? That medial meniscus, all right? That's where the medial meniscus would go, and here there would be the lateral meniscus. Lateral meniscus. All right, so far so good. So what is exactly shown to us? Well, we are shown that these are the two areas where posterior cruciate ligament would attach. So why are we calling it posterior cruciate? Because that is with respect to this tibia. With respect to this tibia. On tibia, this is a posterior surface, posterior view. So that's why this is connected to that. So where exactly on tibia? So this is intercondylar area, but the posterior part, right? Posterior part. And it is behind medial meniscus. This makes complete sense because medial meniscus would be all the way like this, right? And like this. So that's the medial meniscus. It is just behind the medial meniscus. So this portion is, right, in between those two condyles. So we'll call this as intercondylar area posteriorly, and the way sometimes we say that, okay, my house is on this lane, etc., but it is opposite to this restaurant, right? So same way over here, it is a landmark. We give a landmark that, well, I'll be there just behind the medial meniscus. But then medial meniscus would say, it will object. Medial meniscus would say, am I a small thing? Right? Medial meniscus would say, I am like this. Okay. So this is what and this is what. It will say, don't they look like horn? Right? This is anterior horn because it would be on the opposite side. We are watching it the posterior. And this one would be the posterior horn. So now be clear. Don't tell someone that just behind medial meniscus. Otherwise this medial meniscus won't feel good. Right? It will say, give the proper location. Behind posterior horn of medial meniscus. Very scientific, right? Meniscus. So this is the reason that all these landmarks are needed, right? So now on tibia, we are crystal clear that where exactly it is attached. Moving on to the femur part, what femur is doing. Femur would say, I am to very seedha sada, right? Wherever the attachment is, just give the attachment because name is not as per my attachment. It is the tibia who is taking all the credit, right? So this femur would say, see the area, it is simple, intercondylar fossa, right? So it will say that it is the intercondylar fossa, obviously the posterior part, posterior, right? Yeah, medial meniscus is circular, but still it would always be like, right? Whenever they are like, so anterior and posterior, so they are called as the horns, right? They are called as the horns. And one more thing I would like to show you. See, it is the medial meniscus which is C-shaped, right? Because we watched from the posterior aspect, so when you rotate it, right, this thing would go on the opposite side. Got the idea, right? So it would go on the opposite side, and this lateral one, that is the full circle. So lateral one is full circle and medial one is right, is like C-shaped. Got it? Do anterior cruciate ligament affect the movement of tibia as well? Well, this is interesting, right? And I'll is like, okay, but Tushar has written anterior cruciate ligament is like police to femur. It tells him that rukja kahan piche. Actually, it is like that. Oh yeah, actually it is like that, right? It is a restrictive band. And when what you are asking, Janvi, is that yes, it would affect the movement of tibia as well when the femur is fixed, right? So when the femur is fixed, so that's the reason that in some of the exercise it would be like when femur is fixed, so it will be affecting the movement of the tibia. No, Harsh, not every time it's possible, because making those 3D, it will be hell of a job. Right? And sometimes the understanding when we draw it, it becomes more clear. Okay, chalo, coming back to our, you are understanding it, that's great. Okay, chalo, this part, just we finish this. This is the intercondylar fossa, posterior aspect, and that's it, right, which is over there. Here it is. This part is posterior cruciate ligament, and over here we have removed the anterior one, right? So this is posterior cruciate ligament, and I'll just write anterior cruciate. This means that it has been removed. Okay. So what would be the purpose? What would be the purpose of posterior cruciate, right? Same logic, same logic, right? The way anterior cruciate was preventing the backward movement of femur. Now this femur, right, it is very notorious, right? So he'll say, ke, chalo, let's try this. Let's try this. The forward movement of femur. And that is what is prevented by this posterior cruciate. Right, posterior cruciate. So it will just it prevents, right? It prevents. So it prevents forward movement of femur. That's the rule, right? Let's put a star so that this is important concept and to be remembered. Now, same way you are right that when the femur is fixed, so then it will affect the movement of rest of the leg, that is the tibia, right? It would affect, because see, these are the bands, right? These are the tight bands which will keep the entire knee joint stable from anteroposterior axis, right? It won't allow the femur to glide forward. It won't allow the femur to glide backward. What about side to side? Side to side, so we do have those menisci, but still there will be something else, right, to make it more clear. Okay. So few images, right? This is no doubt, that's the patella, right? This is the patella, and that one is our anterior cruciate ligament. And we are dealing with right side, right? So this is medial, this one is lateral, right? Due to this, okay. Here it is, right? Straight away you can see that which aspect it is. This is the posterior view, right? That's the posterior view. Just look at the condyles seen so prominently. And this one is posterior cruciate ligament. And this shy one, right? It is anterior cruciate ligament. Now see, when we look at this, they don't cross like this, है ना? So that's the whole idea. Okay. And here it is. Just we have removed the entire femur. So as if now you are sitting on the femur, the femur has been removed and then you are watching this articular surface from the top. So that's where you see that this is how the posterior and that's how the anterior cruciate ligaments, they are connected, right? And see, this one is medial meniscus, right? This one is medial meniscus, and this medial meniscus is C-shaped, right? So that's why this one would be the posterior horn, ठीक? And this lateral meniscus is almost like a full circle, right? It is like a full circle. Good. Right. Now we come to that for that side to side movement. Now again, it is because it is a real specimen, so we see some things superbly well. One of the thing is this. These are menisci. See how nicely seen, right? These are the menisci. Now, because movements are focused in specific plane, so these are the structures which are supporting from side, right? So that's where they are called as the collateral ligaments, right? Let's see them in more detail. The first thing first, let's orient. This is posterior, correct? See the prominence. And this one is anterior side. Okay. Now this capsule, right? Because now what you are watching is the entire capsule. This capsule, this is tibia, right? Just from the size itself, that's the tibia. And this smaller one, this one, that's the fibula. Okay. That's the fibula. So here, can you see a big band, right? You should be able to, I'm just highlighting it. See, this one, right? A big band sort of thing. Now I'll remove it so that you can see properly. Here it is, right? This is tibial collateral ligament, right? Now this one, so that is tibial collateral ligament. Now there is a difference between tibial collateral ligament and the fibular collateral ligament. There is a difference, right? Obviously this is tibia, so we are dealing with, right, no big thing, medial side, right? In case if there is any confusion, right? So these are the medial side. Now this tibial collateral ligament, it blends with the capsule, right? Anterior and posteriorly, right? It blends with the capsule, and so much so it is finally attached to the medial meniscus also. So we can see all these things amazingly well. See, that's the collateral ligament, and then it fans out and it is merging with the capsule. So much so that over here, even on the meniscus also, it is attached, right? Over here, it is attached, right? So the point which will write it over here is, let's change the color and we put a star, because things would be completely different when we'll be dealing with the fibular collateral ligament. So it blends with capsule, right? Anterior and posterior plus medial meniscus, right? So that's where we'll see that yes, this is all blending. See over here, it is blending with the anterior capsule, right? So thus it gives a good support. See, the moment you'll watch, you'll say that, okay, we got the idea, right? This is like now lateral side, right? Say this is a big bone, so that's the tibia, this is tibia, and this one is fibula. So it means now we are dealing with, this is the lateral part, right? And this is fibular collateral ligament, fibular collateral ligament. And all we need to remember in this case is, and we'll put a star again, that it is outside the joint capsule, outside the joint capsule. Rest all is easy, right? That where exactly this fibular collateral ligament is attached, simple, because this area we described that this is head, so it is attached on head of fibula, head of fibula, right? Where exactly it is attached on the femur? Well, it is like the lateral epicondyle, right? It is just below that. This one is condyle, so we can say this is lateral epicondyle. Done attachment. But this part is important, which others would forget. You should not. It is outside the joint capsule. Do remember, right? See, right? It is not blending, completely separate. Right? It is this collateral ligaments, right? Whether any of the collateral ligament. So these collateral ligaments, they will be tight in extension, right? So see how nicely the whole thing is constructed, that these are menisci, right? So a good cushion is given so that things they can slide comfortably. But then there is anterior cruciate and the posterior cruciate, which are preventing that's anterior anteroposterior excessive movement, and side to side there are collaterals. Now this is the reason that in lawn tennis many times just to return that shot, right, they extend so much, and that's where these ligaments, cruciate ligaments or the meniscus or these collateral ligaments, they are damaged, right, when the movements are excessive and along with the force, right? So that's the reason. So when things are flexed, right, when things are flexed, so they will be less tight in flexion, right? It is very obvious. So they'll be bit loose. So this prevents, so these are the collateral ligaments which prevents like side to side movement, right? There would be as such, if you see that when the one interesting thing, you can try to do it even right now. Extend your knee, right? Just experiment it. Extend the knee, and then can you do any medial or lateral rotation, right? I'm putting a question mark. Medial or lateral rotation of your leg, that is below knee joint. You'll find that that is not possible, because even when you try to, you are just moving the foot, and if you try to rotate, then you are rotating the entire knee joint. But when you flex your knee joint, and then if you try to rotate, you'll find that there would be some movement. So this is very interesting, that when the knees are flexed, knee is flexed, right, there would be some, not much, right? Because it is well guarded, but there would be some medial and lateral rotation. But when you extend it, right, everything, the capsule is tight, collateral ligaments are tight, so then they won't permit any movement, right? So that's the important concept. Now from the anterior aspect, right? This is quadriceps tendon, right, which we were watching from the side, right? That is the quadriceps tendon. Then inside that's the patella, correct? So patella inside, and this one. So it is what? It is nothing but quadriceps tendon, right? But this lower part of quadriceps tendon, less tight in flexion means, less tight means it is loose, right? So here is the bone, one bone, two bone. When they are extended, so they are tight, right? They are tight, right? Simply just tight. And when they are flexed, right? So this is one bone, this is like a bent knee joint. So they are bit loose over here. They are bit loose, right? So this is, they are bit loose, and over here they are tight, right? That is extension, and this is flexion. Because when you flex, right, when you flex, obviously the distance is decreased. So distance is decreased, so that collateral ligaments, right, they would be bit loose. Got it? One more important thing, quadriceps tendon, though it is all the way from up, but when it crosses this patella and only this much area, right, it is definitely a quadriceps tendon. But now we'll say that no, it is the bone to bone connection, right? Now quadriceps must be feeling so bad, right, that see, this is like cheating, right? I came all the way from the thigh, right, forming this tendon and giving shelter to this patella, right? And now this patella is doing, he is telling that, okay, all anatomists, right, for this structure, say patella, I am a bone, right? Over here, tibial tubercle, it is a bone. So now onwards, you'll declare this thing as ligament, right? And whose name should be? Patella would say, obviously my name, so we'll call it patellar ligament, right? But deep in the heart of this quadriceps tendon, right, he is not very happy, because he is knowing that it is nothing but it is the lower part of, right, quadriceps tendon, right, quadriceps tendon. So this is how, right, with one small tear, right, this quadriceps must be feeling. But well, that's okay. That's like patellar ligament. Okay. So again, this is important point. We'll put a star. Hmm. On the medial side, right, we'll see that it is continuous with the capsule. So on the medial side, this tendon is continuous with the capsule. Why we are telling this? Simply for one reason, strength. It strengthens. Because after nomenclature of this patellar ligament, right, so it is like that one is patellar ligament, right? Clear? And it blends with the capsule, right? As such, it is tendon of quadriceps. This is a lateral view, right? And if I say this is a lateral view, just one important landmark, and that will make the picture clear. And this is, what is this? What structure is this? Right? Someone who is separate, who is not taking part into any of the capsule, and that is the fibular. You must have written fibular collateral ligament. Right. So many things are there into this. This one is, okay, femur. What I really want to show you is the bursa. Bursa. Bursa is something, right? You know bursa? Bursa. I'm not speaking in Hindi, right? So it is not like barish. This is a say it's lined with synovial membrane. Synovial membrane, right? It is a fluid filled cavity. It is fluid filled. And the muscle in which it is named accordingly, right? So there can be only one muscle, right? That is quadriceps. There cannot be anyone else into this territory. So this is quadriceps. So we'll call it a quadriceps bursa. So where is this quadriceps bursa? This quadriceps bursa is, watch it here. That's the quadriceps, right? So see how interesting. There is femur. On that there is bursa. On that there is this patella, and this patella comfortably glides, right? Comfortably glides, and quadriceps has done so much good for this patella. Imagine still he has, right, done this. True? You know that. Now, so purpose of bursa is for lubricated movements, right? So we'll just write it over here for lubricated movements, smooth movements. And the day this bursa is affected, and there starts all sorts of pain, right? Yeah. Okay. Over here, the back side, right? See, this is at an angle. The medial aspect. We are just watching the joint, right? So this joint, this is when the medial aspect. So this one is the tibial. In fact, it is not exactly the medial aspect, right? This is slightly at an angle. So this is like tibial collateral ligament, right? Patella backstabbed quad. Yeah. Yeah, it backstabbed. So tibial collateral ligament, right? There is, this is the joint, right? So there is all this, if you see, right? This is the capsule. So that's all the capsule surrounding it, right? So it is the capsule, and it is continuous with tibial collateral ligament. In fact, we have already talked about it, right? Tibial collateral ligament. This is how it merges, right? And it is continuous with the capsule. Now, interestingly, this entire capsule, right? It is quite thick, right? It is quite thick. So capsule also supports the stability of the knee joint, right? So capsule also supports stability. So this is the entire capsule. Now, if you just put a nick, right? If you put a small cut, right? And then when you peel it off, this is the inner side. That's the inner side or the inner surface. This inner surface of capsule. And this entire world which is inside, right? It is highly lubricated. It is exactly like a gearbox, right? When you see the gearbox, it is filled with fluid, filled with oil, right? And all the gears, they are moving inside. So over here also, right, these capsules, they just pack the whole knee joint, and then inside those gears, right, these bones, they are moving. So they are this inside surface of capsule, right, that is lined with, right, that is with synovial membrane. Synovial membrane. And it is synovial membrane which keeps on lubricating the synovial fluid, right? And that's the synovial fluid which is acting like a lubricating fluid, right? That's like a gearbox. So this is okay. So muscles are starting from here. So that will take tomorrow, right? So we stop at this point, and this was the entire knee joint. Now tomorrow we'll see that how we put muscles on that, and then they will start working on various axes, right? So thank you so much. By the way, yesterday it was a pleasure talking to all of you. I have kept that session into my archives now, right? And there is a link, so if someone wants to see that, right, I'll send a link. But otherwise, I'm not putting it directly onto our channel, right? So thank you so much, and we meet tomorrow, same time, right? I'll save this, and I'm putting this thing into our common folder, right? And from this point, we'll start tomorrow. Is running and weightlifting bad for the bursa and menisci? Not at all. Not at all. It is not at all bad. But the thing is when done correctly, right? Because see, when you do the weightlifting, right, you must have noticed that even why weightlifting, even when you do simple squats, right, at that point you are putting tremendous load on your knee joint, but nothing would happen, right? There are good muscles, right, they will be taking care. But in case when the weights are more, and if there is any misalignment, so any of the jerky movement, sharp movement, they can damage the structure. Otherwise it is not bad. How the meniscus affected during running? Nothing. Matlab, it is just a normal sliding mechanism. Iliotibial tract? Well, iliotibial tract is what we'll be including when we'll see the muscles, right? So I think that at that point it would be much more interesting. Right? Today we went it's quite slow, so it was as good as a revision, but still tomorrow we'll try to include it. Right? The synovial membrane, this inner part, right? It is the inner part, because all these bursa and everything, yes, you can mark it, right, in the real dissection, but you have to be very fine to see those bursas. All right, so thanks a lot, and see you tomorrow, right? Same time. Bye bye.